Hello, everyone. Thank you for joining us today for our webinar entitled Understanding the 2019 MIPS Cost Category. Today's primary presenter is Beth Hickerson, Senior Consultant at Medical Advantage Group. My name is Bruce Mackey, and I am today's moderator and co-presenter. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for us, please type it into the questions box of your GoToWebinar interface. We'll take the time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will be posting the presentation slides and a recording of today's webinar on our website, www.qppresourcecenter.com. Also, the presentation slides are currently available for download in the handout section of your GoToWebinar interface. Today, we'll start off with an overview of the MIPS cost performance category, describing the 10 cost measures being used in 2019, as well as the attribution process, which governs which, if any, of the cost measures apply to program participants. From there, Beth will discuss cost measure scoring, including the new facility-based scoring option, followed by a look at the cost category feedback from 2018 and how you can use that information to your advantage to improve your future cost category score. We'll then finish with a brief look ahead at how the cost category is proposed to change in future program years. With any time left, we will address questions posed by the attendees during the broadcast. Please note the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Beth.
Thank you, Bruce. Good afternoon, everyone. Thanks for joining today. Couple caveats before we begin this presentation today. I want you to understand that this presentation is meant to make you feel empowered and give you a better understanding of the cost category. We are not going to go into the specifics on exactly how every single measure is calculated, all of the exclusions applied, all of the adjustments applied. The more important aspect that I think you need to understand is what is included in each measure. What are you actually being scored on? How do you know whether it applies to you? How do you find the feedback report that CMS is providing to you? And then what do you do with that information afterwards? So we'll get started from there. Next slide, Bruce. So the cost category is just one of the four MIPS categories. For 2019, it's weighted at 15% of your MIPS final score. That weighting will continue to increase each year until it hits 30% in 2022. Cost and working on improving cost is definitely a long game. So although the full weighting doesn't hit until 2022, now is the time to start working on it because the improvements that you put in place will take time for you to see the effects of. Next slide. So these are the primary categories of the cost measures. I'm just going to cover them really briefly so you have some context as we move on to the next portion of the presentation. There are two overall cost measures. The first is total per capita cost of care, or TPCC as it's referred to. That measures all Part A and Part B costs for a beneficiary for the entire performance year. In order to be measured on this measure, a group or clinician, however you're reporting, needs to have at least 20 attributed patients. The next overall measure is Medicare spending per beneficiary, or MSPB. I personally don't love the name of this measure. I don't think it's at all descriptive for what it is, which is all Part A and B costs related to a hospital index admission for an acute inpatient condition or for a procedure. For an acute inpatient admission. In order to be scored on this, a group or individual needs to have 35 minimum attributed patients. And then the final kind of category we're looking at is the 8 episode-based measures. So these are costs associated to a designated procedure or acute inpatient medical condition. Those costs are only surrounding that specific episode. And in order to be scored on this, a clinician or group must have a minimum of 10 attributed patients if it's a procedure-based episode, or a minimum of 20 patients for an acute inpatient condition. Next slide. So one question I get a lot from practices is, for instance, if I'm working with a specialty practices, how is CMS comparing me to other specialties and other providers, for instance, primary care? How am I expected to compete with primary care? So my answer to that is that CMS has a number of adjustment processes that they use when they are taking the data and converting it so that they can compare roughly apples to apples. Certainly these adjustment processes aren't perfect. They don't account for every possible variable, but they are certainly better than not having any adjustment. So we're going to go through the general idea behind these adjustments, and so you understand what they are. We're not going to discuss exactly how these are applied to each measure, but I just want you to have an understanding of what happens behind the scenes before you get your feedback numbers. Next slide. So payment standardization is the method that normalizes Medicare payments to account for factors unrelated to actually providing the care. So this would be, for instance, difference in geographic rates. It's obviously more expensive to provide care in California than it is in Ohio or Michigan. And also for any add-on payments for things like medical education. So if a clinic has medical residents, there may be additional payments made on claims to account for that extra time and resources being invested on the practice side. Next slide. Annualization is the method for calculating full year estimated expenses for those beneficiaries that are actually only in Medicare for part of a year. So reasons that a Medicare beneficiary may be in Medicare only for part of a year is either that they started partway through the year or that they died during the year, and so they weren't covered for the entire year. So CMS basically just takes the full amount of their costs divided by however many months they were actually enrolled in Medicare, and then multiplies that by 12 to get their annualized cost. Next slide. Specialty standardization is the method for normalizing costs across specialties based on the clinical complexity of patients treated by that specialty. So for instance, an oncologist generally treats patients who are more complex than a primary care provider would. Next slide. Risk adjustment is the method for normalizing clinical complexity across patients. So risk adjustment is done at the patient level, and the factors that CMS uses for this risk adjustment include HCC codes, long-term care status, whether or not the patient has end-stage renal disease, and their Medicare severity diagnosis related group, or MSDRG. Next slide. And finally, this isn't an adjustment process so much, but the attribution process is how CMS decides which patients are assigned to which physicians to be responsible for their cost of care. So for instance, if a patient sees 5 different providers who are billing Medicare for that patient throughout the performance year, how does CMS decide which of those providers is responsible for that patient's cost of care for the year? Next slide. So let's talk about each of the different cost measures individually in a little bit more detail. So total per capita cost of care, I'm going to just call it total cost of care for the sake of not tripping over my words. Next slide. And this looks at the total Medicare Part A and B costs for a beneficiary during the performance year. Essentially, CMS is going to take the cost of all the attributed beneficiaries for an individual or group and divide that total cost by the number of beneficiaries to reach an average total. In order for, again, for a provider or group to be scored on this measure, they need to have a minimum of 20 attributed patients. So the next logical question there is, how does CMS attribute this? So next slide. So there's just a 2-step attribution. It's fairly simple for the total cost of care measure. First, CMS is going to look for whether or not the patient received any primary care services, and essentially that's going to be any outpatient E&M code that might be billed for an office visit. So did the patient receive any primary care services from a designated primary care provider? We're going to talk in a second about how CMS determines whether someone is a primary care provider. But if yes, then CMS will attribute the patient to the primary care provider who billed the majority of allowed charges for the year. So essentially, whoever got paid the most for the patient's care that year would be attributed the patient. Now, the second step of this process is if a patient did not see any labeled primary care providers during the year, then CMS will look at all of the specialists who may have provided care, and CMS will attribute the beneficiary to the specialist who provided the majority of Medicare allowed charges for the performance period. If a patient did not see any primary care specialists, obviously they won't be attributed to any TIN or NPI. Next slide.
If I can interject here, I want to point out too that we are seeing some issues in this attribution process where some of those mid-level providers who are working for specialists in specialist offices, let's say they're doing pre-op visits, they end up billing those outpatient E&M codes. And we're seeing some kind of muddying the waters there, where these NPs and PAs that are working under specialist physicians are then getting attributed those patients. So I think the general consensus is, we'd like to see CMS make some adjustments to this attribution process to account for that, but kind of stay tuned to see what kind of adjustments can be made, or if CMS is even willing to make them.
Yep. So this slide tells you exactly who those primary care clinicians are. So essentially general practice, family practice, internal medicine, or geriatric medicine. And as Bruce just mentioned, the advanced care nurses are also include primary care. So it doesn't, if you have an NP, a PA, a CNS in your practice and you're a specialty, it doesn't matter that they are working in a specialty, providing specialty care, just by designation of their license type as an advanced care nurse, then CMS is going to designate them as a primary care provider, which Bruce mentioned is causing some issues with attribution, which is inappropriate. Another comment that I want to make here that I've seen happen is that most clinicians, the way that CMS determines these category types is by the specialty designation listed in PACOS. So PACOS is the online enrollment system for Medicare. In my experience, what I've seen happen sometimes is that when a clinician applies for their NPI, they're often in their residency program. So when they are finished, if they're going to go into a specialty later, when they're finished with their residency program, then they have an internal board certification. And so their specialty in PACOS is listed as internal medicine. Later on, when they complete their fellowship and become board certified in whatever their specialty or subspecialty may be, sometimes that specialty gets added as the secondary designation in PACOS. Sometimes it doesn't get added at all, just depending on who's handling PACOS for a practice or organization. So if you have, let's say, a nephrologist who in PACOS, their specialty is designated as internal medicine only, or as their first specialty, then they will be considered by CMS as a primary care provider for attribution in the first step of this model. So I recommend that you make sure that the specialty listed for providers in PACOS matches their specialty or subspecialty if that's applicable for your providers. Next slide. We're going to move on to the Medicare spending per beneficiary measure. Next slide. So MSPB assesses total Medicare Parts A and B costs incurred by a single beneficiary immediately prior to, during, and 30 days after a qualifying event. And CMS is comparing observed costs or actual costs to expected costs. So CMS has a general calculation to anticipate what an inpatient stay might cost depending on what the diagnosis codes are or issues that the patient has. And so they're going to look at the costs that were actually incurred in real life. And those costs would start 3 days prior to an admission, throughout the entire admission while they're there, on the date of discharge, and 30 days past the date of discharge. So that entire period is called an index admission. It's a date range rather than just strictly only the time they were in the hospital. If your clinicians in your practice never see patients in the hospital, they never perform consults in the hospital, they won't ever have attributed patients for this measure, by the way. For physicians or groups that this does apply to, keep in mind that there is a minimum of 35 attributed patients necessary in order to be scored on this measure. Next slide. Again, I talked about, what observed costs really are, the actual billed costs versus the expected costs just based on the patient's age, enrollments, comorbidities, that kind of thing. One note I have listed under observed costs for you here, the types of charges that are counted towards the total cost for this particular measure. Next slide. So as far as attribution for this measure, each episode, this is a bit convoluted, but each episode is attributed to the MIPS eligible clinician who billed the largest amount of Medicare Part B claims during the index admission period. So again, the largest amount of Part B claims refers to the dollar amount of allowed Medicare charges there. And these would include Part B services provided on the admission date in a hospital setting with a place of service as hospital inpatient, outpatient, or emergency room. It also includes Part B services provided during the hospital stay, regardless of the place of service, and Part B services provided on the discharge date with a place of service restricted to inpatient hospital only. So it is a bit confusing there on exactly what's included or what's not, but you'll have the slide as reference in the future. Next slide. So let's talk about episode-based measures. Next slide. We're not going to talk about I have a slide next coming up of all the 8 episode-based measures for 2019. We're not going to talk about them in detail. I'm just going to give you an overview. But the episode-based measures overall assess the cost of care that is clinically related to an initial treatment of a patient provided during the episode's time frame. So the episode's time frame varies a bit depending on what the actual episode measure is. But know that for the procedural-based episodes, there is a requirement of a minimum of 10 attributed patients to be scored, and for the acute inpatient medical condition group, there's a minimum of 20 attributed patients required for scoring. And the next slide shows, Bruce, if you go to the next slide, we've got the lists of those procedure versus acute inpatient measures, so you can see what they are. You can scan this list right now. Obviously, if your providers don't do any of these procedures or they don't treat patients in the hospital, they are not going to have any attributed patients for these measures. Next slide. As far as attribution, for the acute inpatient medical condition episodes, those are attributed to the eligible clinician who bills E&M claim lines during the inpatient hospitalization event under a TIN that renders at least 30% of the inpatient E&M claim lines during that event. So essentially, CMS is first going to look at, is there any TIN that billed at least 30% of the claim lines for this episode? And if yes, then any individual NPI that submitted a claim for that event during the time period would be assigned to that patient or attributed that patient. So this means that for these measures, these episode-based acute inpatient medical condition measures, there could be more than one clinician who is attributed a single patient. Multiple clinicians could be attributed to a patient, the same patient. And next is the procedural episodes. Those are attributed to the eligible clinician who renders the triggering service as identified by procedure codes. Next slide. So we're going to talk about scoring for a minute. Next slide. CMS, when it comes to scoring the cost category as a whole, they're going to look at the scores on the individual cost measures. If you are only scored on one of the possible measures, then your cost category score will be equal to that one measure score. If you are scored on multiple cost measures, then CMS will average the scores on those measures weighted equivalently across all measures to determine your cost score. For instance, if you score 3 on one measure and 4 on another measure, then your average would be 3.5, and that would be your cost category score. If a provider does not have any cost measures that can be scored because they don't have attributed patients or it doesn't apply to them, then their cost points will be reattributed to quality. And that means for 2019, that quality would become worth 60% instead of 45%. Next slide. This is an example of cost scoring. I'm not going to go through this one by one, but if you wanted to break it down later and you needed a little bit more help understanding this, I did pull this off of the CMS website directly in one of their guides that's referenced at the end of the presentation. Next slide. Next slide also. So facility-based scoring is a new option for 2019, and the gist behind this is that CMS wanted to allow hospital-based physicians to be scored based on the total hospital's quality reporting rather than their own individual scoring. So an individual MIPS clinician would be eligible for this type of scoring if they furnished 75% or more of their covered professional services in place of service for inpatient emergency room or on-campus outpatient hospital. They also have to have at least one service line with one of those place of service codes during the first segment of the MIPS determination period. So for instance, maybe they came into a new hospital later in only during the second determination period, then they wouldn't necessarily fall into this category. And finally, they must be able to be attributed using the CMS methodology to a facility that has a value-based purchasing score for the applicable period. So if they are working in a hospital that doesn't report for the hospital-based or the hospital value-based purchasing program, then this wouldn't apply to them. As far as a group, if you're reporting as a group, then a group would be eligible for this if 75% or more of the eligible clinicians within the group qualified for the facility-based scoring. Next slide. This slide breaks down if a clinician were going to multiple facilities and all of the facilities they went to all had eligible value-based purchasing scores, then how would they determine which score would be applied? And essentially it would go to whichever facility had the higher score. Unless there was a clear indicator that one of those facilities was utilized more than the other. There is a fact sheet linked here to find out more information. I don't want to this is kind of complicated. I don't want to spend a ton of time on it because it doesn't apply to everybody on the call. If you do have questions though, you can of course feel free to reach out to the QPP Resource Center to ask those questions later. Next slide. Okay, so we're going to talk about cost category feedback now. Next slide. One thing that I love about QPP for, the MIPS program is that all of your reporting and your feedback reports are all found in the same place. You don't have to go to different places to find them like you used to have to with previous programs. I don't think CMS has quite gotten down the user interface, however, because it's not always really intuitive where you need to go for all of these reports. So I've included several screenshots here. So when you go look for this feedback for yourself, that you can kind of easily identify what you need to click on to get where you need to go. So first off, you'll want to print your entire feedback report. So in order to do that, you will log on to the QPP portal. You will click through the obvious screens telling you view performance data or view practice data until you get to a screen that looks like this. You see the fancy colored circle down there towards the bottom. It will say overview, and then you have your practice name under it, or overview with the individual clinician's name under it if you report it as individuals. From there, you can scroll down that sheet in order to see all the scores, but it's really helpful for future reference. If you go up to the upper right hand corner where it says print and you click the down arrow, and it will give you some options. And if you print entire feedback, then it will download a PDF version of the full feedback report. You can either save that to your computer or you can print it out, either one. Next slide. Now, unfortunately, that entire feedback report doesn't include all of the detailed cost information within it. So you also have to print a secondary report for yourself. So you would actually click from that overview screen. You would go over to that dark blue left-hand panel. You would click on cost, and it would take you to this screen here. Again, it will say cost at the top with either the practice name or the individual provider name under it. I failed to highlight that same print drop-down menu up in the upper right-hand corner, but if you go there again and you click on that and print it, then you will get a PDF version of all of the results that you see on this page, including the expanded sections. Yes, right there, Bruce. Thank you. Including the expanded sections that we're going to talk about next. So next slide. If you were to scroll down on that cost page that we just showed the top of, you would see the individual measures that applied to you available. However, they don't show the full expanded view. They only show the one line here where it says total per capita costs. It only shows that line, but you'll notice over at the far right where we've highlighted with an orange box here, there's a drop-down menu. Drop-down arrow. If you click on that, it will expand to give you this full information that you see on this screen. Now I know this is really tiny, so we're going to go to the next slide and we're going to break this off into two pieces. So again, these results are not necessarily super intuitive, so we're going to walk through them so you know what you're looking at exactly. So for the total per capita costs measure, in the yellow box there, what you're seeing is the average cost per beneficiary when that cost has been fully adjusted. So we talked about adjustment processes at the beginning of the presentation. This yellow box accounts for any adjustment done as a part of this measure overall. Again, this allows CMS to compare apples to apples among specialties. If you go down to the purple box, you'll see that it tells you the number of eligible beneficiaries that the clinician or group had for this particular measure. The next number down, that unadjusted per capita cost, is just what it says. It is the average cost per beneficiary before it goes through all of the risk adjustment and total adjustment process. So that was more of a raw number. I think you can safely ignore that number because the one that you are actually measured on in terms of the benchmark is the number that you see circled in yellow towards the top. And then the last thing you have in that purple box is the total per capita cost ratio. So essentially this ratio says how the individual or group is performing compared to the national benchmark or national average. So if your ratio here was 1.0, that would mean that the individual or group had was right at the national average. If you are under 1, that means that your costs are below the national average, which is a good thing. If your costs are above 1, then that would mean that the costs are above the national average, which would be less desirable. And you'll see there in the red box at the very bottom, you'll see the measure score. Now, I do want to mention here, please be aware that when I'm seeing feedback reports from practices, this is literally the only score of a 10 or even of a 9, which we'll see in a minute, that I saw in any practice I've worked with so far. This just happens to be a practice that I have access to their screenshots, so that's why I use them. But if you go down to the next slide, Bruce, please don't be alarmed if your score is 0 or 1 or 2 or 3 or 4, because that's what we're really seeing much more of when we look at these feedback reports. And you can understand that if we break down this table for you here. So essentially, when CMS is creating the scoring for these measures, then they create a benchmark range. And so the TPCC range for 2018 ranges from 10,082, which you see all the way over at the right-hand side of the table, because in this case, less is more, and less is more desirable. And the range goes all the way up to almost 80,000. That's obviously a huge range, 10,000 to 80,000. When we're looking at that, the black oval that you see at the far right-hand side of the screen, the 8,600, that's the same number that we saw in the previous slide with the fully adjusted average. And that oval will be over whichever decile the practice scored in. So we see it in the 10th decile here on this slide because that's where the practice scored. CMS takes this benchmark range, divides it into 10 equal ranged deciles, and that's how they create the scoring. And that's what you're seeing in these different columns here on this table. Now, it gets a little confusing because CMS elected to combine decile 1 and decile 2 into just one column over on the far left. That's where you see that really tall green column. The columns, according to the axis, the vertical axis over on the left, what that tells you is the percentage of the country that scored within that decile. So on the far left, we see that about 85% of the country fell in decile, well, 1 or 2, or even below the range or above the range altogether, and scored 0. So about 85% of the country then scored within those deciles. So this takes a little bit of mind bending to get around because we're used to seeing quality measure benchmarks. And if you're at a 2 or a 3 on a quality benchmark, it looks like you're doing really poorly and you're doing well below the national average. But with quality, the way they score this, if you get a 2 or a 3, you're actually doing better than the majority of the country. So that's not necessarily a bad score. So please understand that when you're looking at your results. You can see then that the remaining 15% of the country then scored in either decile 3 through 10, spread out towards the right on this graph. Next slide, Bruce. So the Medicare spend per beneficiary information looks very, very similar to this. We'll go through it really quickly. In the yellow box, you have the fully adjusted average cost for per beneficiary or per episode. In the purple box, you have the eligible number of episodes for the group or individual. You have the unadjusted per episode cost. Again, just for the fact that there's so much information to take in, you can somewhat ignore that number. And then you've got the MSPB ratio, and that ratio is looking at observed or actual costs compared to expected costs. So again, if you are under 1.0, that is quote unquote good. If you're over 1.0, that means that you're above the national average. And then the red box is the measure score, again, based on the amount that's in the yellow box at the top. Next slide. The table for this looks very, very similar to the total per capita costs. So you see the entire benchmark range for the measure laid out from highest cost on the left to lowest cost on the right. You can see that in this instance, about 78% of the country scored in either 0, 1, or 2 deciles, and the remaining 22% of the country then is spread out between the 3rd and 10th decile. Next slide. So this is the very bottom of this screen. When you look at it, will just tell you the exact cost calculation for your provider or practice. You can see here that this particular sample practice that I've shown you, they received a score of 9 on one measure, a score of 10 on the other measure. They did not have any episode measures attributed to them, and they had an average score of 9.5 then for the cost category as a whole. Unfortunately, I did not have access to screenshots for any episode measures. Bruce, have you seen any of those, the detailed reporting for any episode-based measures. I assume they look very similar
Yeah,
to
from what
we
I've
saw.
seen, yep, from what I've seen, they look strikingly similar to the two that you've shown already. So you don't have to reinterpret the others. If they apply to you, they should look a lot like those screenshots you've already seen here.
Okay, great. All right, next slide, Bruce. All right, and one more slide after this. So in addition to that breakdown of measure data, CMS is also supplying you with supplemental data. So this is practice or patient level data on all of the beneficiaries that were attributed to you for each measure. This is similar to the kind of information you used to see in your QR/UR reports. We didn't get this for 2017 for MIPS, so I'm glad to see that it's come back. The way that you would download this is if you're looking on your cost page on your QPP report, you can see highlighted in the orange box there, there's a little line that says download beneficiary level data. If you click on that, it will auto download an Excel spreadsheet for you, and that will include all of your patient data, like I said, for the attributed patients for that measure. Each measure has its own list, so you will have to go in for every measure that you are scored, go in and click that download data button to get separate lists for each measure. Next slide. So there's a lot of columns on this spreadsheet. I can't fit them all on one screen, so I've broken them up here. But you'll see on the left hand of your spreadsheet, when you're looking at it, you'll see all of the essentially patient identifier information columns. I have obviously cleared out the contents for the Medicare identification number and the attributed NPI and TIN and the date of birth. Just obviously, I'm not going to share somebody else's PHI with you. One thing to note when you look at this table, what we're seeing so far is that every single patient has a date of birth listed, and that same date of birth is also listed in the expired column. Obviously, that's not helpful. Not all of these patients expired on the day they were born, or they wouldn't be in the Medicare program to begin with. So for now, you might just need to hide that expired column so it doesn't confuse you. Some of the patients on this list, at least for total cost of care, may have expired during the period, but you're not going to be able to see that immediately from this spreadsheet. You're going to have to go looking in your EHR. I think it's really helpful that CMS has included the HCC percentile ranking for each patient, and they've told you really easy whether or not diabetes, coronary artery disease, COPD, and heart failure are chronic conditions associated with this patient or not. One note on the gender column there, they've indicated 1 or 2 for male or female. Unfortunately, there is no key anywhere for these downloads, so I can't tell you whether 1 is male or female, but I can tell you that if you just look up that patient in your EHR, you'll be able to identify that very quickly. Next slide. So all of the right-hand columns when you download the spreadsheet are going to be then the actual costs associated. You'll see in column L on the far left, you've got total scaled cost. So that is the cost including all of the categories further to the right. And you see multiple different category types for each patient and what was included in that total scaled cost. One not so helpful thing on this is that column W says all other services. And again, there's no key for these spreadsheets, so I'm afraid I can't tell you exactly what all other services encompasses. That part is not very helpful. Hopefully, as if CMS publishes a user guide or a tip sheet for these spreadsheets, that information will be made more clear. Next slide. So these spreadsheets, if you take them just at face value, are not going to give you a lot of information. What you need to do is pull up these patients in your EHR and see what information you can find about them. Now, depending on how many attributed beneficiaries you have, if you only have 10, you can look them all up. If you have 200, you probably don't have the time to do that. So I recommend that you sort by a couple of different categories here. So the first is total scaled cost. Let's just sort so that we see who the highest cost patients are. A personal note to you here, if you are not sure how to sort in Excel, please make sure you have somebody show you how to sort the entire worksheet, because if you don't do it correctly, you're going to end up scrambling all of the data within the spreadsheet. So in this case, we sorted by total scaled cost, largest to smallest. And you can see then that the first two patients on the list had significantly more cost than others farther down the list. What we find that is not surprising, if we look farther over to the right in the light green squares, is that these two patients had inpatient hospital charges and post-acute services and ED services. So inpatient, ED, and post-acute services are by far the most expensive services that a patient can incur. So it's not a surprise that the most expensive patients in this case have it. However, that's not always going to be the case, because if you look at patients 3 and 4 on this list, then you'll see that they actually don't have any inpatient hospital charges and no post-acute charges. If you could see this chart farther to the right, you'd see that both of them have a fair amount of charges in the other services category, which again is not very helpful because we don't know what that means exactly. You may be able to figure it out, however, when you look up the patient in your chart. So I recommend that you have this spreadsheet pulled up, you sort it, and then over on the far right column, you can have notes. And as you're looking up the patients in the EHR, you can make some notes about them. So you can, for instance, maybe note what they were hospitalized for, what their chronic conditions are, which hospital they were at for these services. Any information that you think that could pertain to explaining the cost would be helpful for you just to note down. It's a little bit like finding a needle in a haystack, but if you do enough patients, you may start to see some similarities there. So, are you able to identify any factors that may have contributed to those patients' high cost? Next slide. The other column that you could sort by is HCC percentile ranking. So these are going to be your highest risk patients according to their HCC score. So we know that high risk patients are more likely to incur high costs. So it may be helpful for you to flag these patients in your EHR, especially if your EHR does not have a global risk adjustment method or score that you can easily access in the EHR that will track it. You could elect to put this in as an optional data point in your EHR so you can track it. Keep in mind, your attributed patients for 2018 are not necessarily going to be the same attributed patients for 2019, but at least for the top, maybe 10–20% of your patients that show up on these lists, it couldn't hurt to have those patients flagged for a little extra care. You could consider enrolling those patients in care management services if you have them at your own practice. If you don't have care management at your own practice, you may consider working with the hospital, especially if the patient had inpatient charges that are associated here on this spreadsheet, because often the hospitals will have care managers that they use to help patients who have multiple comorbidities and have a high risk so that they don't end up back in the hospital. Next slide. Another potential sorting option here is the emergency services not included in a hospital admission. I think that's an interesting field to sort by because you may be able to identify patients who might be inappropriately using the emergency department. So maybe when you look up these patients at the top of the list, you might find that they, perhaps it's a diabetic patient who's only been in once over the last year and they are not showing up for their appointments. You can't call and hound every single patient on your patient list, diabetic patient, to make them come in, but if you can identify those at the highest risk who are costing the most money or maybe inappropriately using the ED, that might give you a small handful of patients to focus on, which might make a big dent. You can, if you've identified these patients as probable inappropriate emergency department utilizers, you could consider flagging them for education next time they do come into the office on appropriate after-hours care options. That will save the health system money, but also more importantly, save them money. Next slide. So I had a large specialty practice that I work with. They used these methods to kind of sift through their data. And when they looked at their total cost of care data, what they found was the following. They found that they had 201 attributed beneficiaries for total cost of care. 10 patients on the list accounted for 55% of the total attributed costs. That speaks to what I was just mentioning a moment ago. You don't have to focus on every patient on these lists. If you focus on the top cost patients, then you'll get a big bang for your buck. Of those 10 patients that accounted for the majority of the cost, 7 patients were hospitalized or in rehab or in an extended care facility, according to the EHR. One of those patients was on dialysis for end-stage renal disease. For any of those patients, it's not really a surprise then that they were high cost of care. The practice did look and see whether there is common diagnosis for the top 10 cost patients, and they did not find any common diagnosis. 45 patients on the list of 201 accounted for 90% of the total attributed costs. So they focused on those. This practice focused on looking at those 45 patients. The practice noted that of those 45 patients that they studied, approximately 40% of those were referred to the practice from the local Air Force Base or VA clinic. So when a patient is being seen at a military base or a VA clinic, those charges are not being billed to Medicare Part B. And if the VA elects to refer out to a specialty that does bill to Part B, that's a very good reason for why the patient may end up being attributed to a specialist and not actually have any primary care visits in the system. And finally, the practice found that many of the attributed patients were low cost and actually positively influenced the group's cost score. So one misnomer is, or myth out there, is that every patient attributed to you is hurting your cost score. Some of them are actually helping your cost score. If you're a specialist and the reason they're on your list is because they haven't had many primary care services or any primary care services from a primary care provider, that may mean that they're actually relatively healthy aside from whatever you see them for, and so then they might be low cost. Next slide. Like I said, you also can download a spreadsheet for Medicare spend per beneficiary. I'm going to go through this a little bit quickly because we're running out of time, but a recommended sorting options for this sheet would be episode cost. So can you identify which patients had the highest cost episodes when they were in the hospital? If you'll note here on this example in the light green squares, you'll see that the highest episode costs, actually, if you look at their lines, they had higher readmission costs than they did initial index admission costs. So this speaks to why CMS and the hospitals are always pushing to reduce readmissions. So for those particular patients, if you look them up in your EHR, could you maybe identify factors that may have attributed to the readmission? So for instance, maybe you notice that your patients who are elderly that live alone are more likely to end up in the hospital for readmission because they don't have anyone helping care for them. Next slide. The same specialty practices that evaluate their TPCC spreadsheet also did their Medicare spend per beneficiary spreadsheet, and they found that they had 320 attributed beneficiaries. 77 patients accounted for 50% of the total attributed costs. The practice reviewed the charts for the top 20% of patients on the list, which was about 24 patients. They found that only 2 of those patients were active established patients with the practice before their admission. They were thinking they may be able to identify a commonality among their practice patients that was landing them in the hospital, but what they really found out was that really most of these patients on the list, they didn't have any access to prior to the hospitalization, so they couldn't have afforded it. They also found that there were no common chronic diagnoses with these patients. In the end, with this spreadsheet, what they learned was that there isn't really much they could do to impact this measure, but they did at least feel like they had a much better grip on who was attributed to them and whether or not there was anything that they could be doing to influence those costs. Next slide. By the way, I presume those spreadsheets are also available for the episode-based measures. As I mentioned, I didn't have access to those. So next, let's talk about improving your cost score just in general, generally speaking. A couple comments on that first, though. Please note that anything you implement now will have little to no impact on your 2019 cost score. You're really planning for the future here. As I mentioned, your attributed patients for 2018 will not necessarily be attributed patients in 2019 or 2020. So really more important than focusing on efforts towards individual patients is looking at the systems and processes that you could implement to address the factors that you identify when you explore the spreadsheets as possible triggers for high cost. And finally, just a note, episode-based cost reductions may be easier for you to achieve than the total cost of care or the Medicare spend. When you are doing episode-based costs, you have, it's an isolated kind of event, fewer factors, and sometimes your practice or provider may be one of the only or just a few providers or facilities involved in that care, which makes it easier to coordinate with others. Next slide. So I think one of the most important things you can do is take the time to comb through your beneficiary patient level data just to get a better understanding of who is attributed to your practice, what kind of factors influence that. Do you have a small number of patients who account for a large percentage of cost? Are there common factors among your highest cost patients? And if your patients go to multiple hospitals, does one facility have higher costs than another? Maybe you want to funnel more patients when appropriate to the lower cost facility, assuming they have equivalent quality of care. I think understanding who's attributed to your practice will help you feel a lot more in the know kind of about this whole cost category as a whole. Next slide. Do whatever you can to avoid unnecessary hospitalizations for your patients. Some hospitalizations are not unnecessary, they're critical. They can't be avoided, but many can be. So essentially what you want to do is make sure that your patients in the outpatient setting have the access they need to your providers to identify whether or not it's appropriate for them to go to the hospital. So implement 24/7 access to clinicians for urgent patient issues. Ultimately your provider probably doesn't want to be woken up at 2 a.m. in the morning, but if it saves the patient from having to go to the hospital for something that they could have just waited until the next day and seen in the office, that's helpful for everyone. Consider expanding to outside of normal business hours, maybe open some same-day appointments on Friday afternoons for those patients who have pushed everything off and now they're staring at the weekend, not sure they can make it till Monday to address whatever issue is going on. And consider implementing care management strategies for your high-risk patients. Even if you're not primary care, there are proactive steps that you could implement in your practice to kind of manage those patients that are at highest risk for hospitalization. Next, educate your billers, coders, and providers on hierarchical condition category coding. This is a topic that we could spend 8 hours discussing on its own, so I'm not going to go into it in depth. My biggest tip for you is to contact your National Specialty Association for guidance and education. HCC coding is really huge and detailed, so if you can get some direction, that will help you narrow in on what you need to do for your specialty and scope of practice. That's a great place to start. But it's important that patients are coded correctly so that CMS fully understands what their overall health condition is, because if they do not, if a patient is not properly coded and CMS doesn't know that they have 4 comorbidities and they think they only have 2 comorbidities, then CMS is going to expect that the cost of that care of patient is lower than it really is, or it should be, because they don't understand the full risk adjustment picture for those individual patients. Next slide. Next, to make the most of your EHR. My company happens to work with a great EHR optimization team. I have never been more convinced of the benefits of EHR optimization than having heard from some of the clients who have just been amazed at what their EHR could do for them that they didn't even know existed. So in my experience, most practices implement an EHR, find the whole process so painful that they don't even want to revisit it. But that next level is the optimization, where you can hire somebody either from the EHR vendor themselves or a third-party consultant to come in and help you customize some reports to identify patients that need a higher level of care. Utilize the built-in test tracking and lab tracking. Are you using all of the functionalities? For instance, maybe there's an HCC coding alert functionality that is not turned on that would help your providers be alerted when a patient maybe hasn't had proper coding. And maybe there are ways that they can teach you to improve the use of the patient portal so that patients can reach your office more easily without undue stress on your staff and physicians. Next slide. So, Bruce, did you want to cover these next slides, or do you want me to handle them?
Sure. Yep, I can do it. So kind of looking ahead to year 4, I know we only have a couple minutes left. We haven't had a lot of questions, so if we have time, we'll address those, but we might have to email you afterward. So looking ahead to the proposed rule that is out, so we get a sense for what they're looking to possibly do next year. There's some changes in that the attribution would be different for individuals and for groups, so there's some changes there in the attribution. I think they still need to take it a step further. A couple of questions we have gotten are related to attribution, so we know that's definitely a confusing piece of it as you try to figure out which patients are being attributed to and why. It doesn't always make sense, we know that. Some specialties who primarily deliver certain non-primary care services would be excluded from the TPCC attribution, and the MSPB attribution methodology would be different for surgical and medical patients. So they're making some of those changes, but again, I think we need to take it a step further. Hopefully, I know there's a lot of pressure on CMS to make some additional adjustments. And they are potentially, I would say, more than likely going to add 10 new episode-based measures as well. They continue to kind of look at the different possibilities here and are continually building new episode-based measures. So we only had the 8 for this year. It looks like we're probably going to have 18 in total for next year. These are those 10 that they're looking to most likely add to the list for 2020. As Beth mentioned on the front side, the MIPS weighting is continually changing as we get through the transition years. We still have a couple years left of the transition years. And through those transition years, we will see the quality weight shrink as those points are added to cost. By program year 2022, quality and cost will be equally weighted at 30%, and with PI at 25% and improvement activities at 15%, where they're at right now. We've got some references and resources here, some additional resources. I highly recommend you kind of pick up these additional resources. There is a wealth of information behind what Beth has already talked about here. She did an amazing job kind of breaking it down, but as you can imagine, there is pages upon pages of information. If you can take a deep dives into each one of those measures, there is, again, just a wealth of information behind here that really we could talk for probably 8 hours just on the cost category.
Hey, Bruce, can I mention just one thing about that,
yeah,
last slide?
Absolutely.
So a lot of this graphics that I pulled for this presentation came from one of these 2 cost resources on the QPP website. There are many on there. I think these 2 particularly do a good job of breaking down the concepts into layman's terms and making it a little easier to understand. They're really done very well. So if this is an area that you'd like to learn more about, it's worth spending 15 minutes to 30 minutes downloading these and just reviewing them.
Great. All right. As part of the funding that CMS pays us to be out here kind of helping you guys, they want to know how we are doing in terms of giving you that information. If you would be so kind as to let us know how we did on this presentation, scale of 1 to 5, with 5 being very satisfied. Interest of time here, we'll just leave this open for just a few moments. Thank you so much for providing this feedback. Give it just another second. Okay. Thank you for that. And with that, We just want to thank you for attending. Beth, that was amazing. Thank you so much for taking time out of your very, very busy day to share your perspective on the cost category. If you're struggling to participate in the QPP, any part of the MIPS program, just know that there's help available to you. We work under the QPP SIRS, what's called funding, and we provide a lot of our service through a web-based platform called the QPP Resource Center that is on your screen right now. If you go there and click the Join Now button, this is a free resource for any and all folks that are working in clinics of 15 or fewer providers. You are considered a small practice. As such, you have free access to all of us. We're here to help you. You go to the QPP Resource Center, we can help kind of guide you through the process. It's also going to give you access to a team of subject matter experts who can kind of guide you through this process. You can pummel us with as many questions as you want, and we'll kind of help you through that process. Another very important component of working with us is that's also going to give you access to what's called MIPScast. That is our custom proprietary scoring platform for the MIPS program. We know exactly what CMS is going to do with your data to score it, and we've mimicked that. Kind of think of MIPScast as a sandbox, as it were. You can come in and kind of give us your data and kind of manipulate it, play with it. We can kind of tell you exactly what CMS is going to score. So cost is a little bit tricky to put in because you are measured not with prior year's data or prior year's benchmarks. It's difficult to get your hands on this cost data. So MIPScast works best for the other categories, but there certainly is some cost component to it as well. Click the Join Now button. You can also email us at qppinfo@altarum.org, and we've got the phone number there for you too. We are part of a 7-state collaborative, so really the entire Midwest is being covered under this website. So there are additional emails and phone numbers specific to your individual state if you're joining us from someplace outside of Michigan. You can ping us with the information on your screen right there, but also if you go to the QPP Resource Center and scroll down on your initial landing page, that's going to get you some additional contact information relative to your specific state. But you can just ping us with the information on your screen, and we'll direct you to those specific resources for your state as well. We are 2 minutes past. We've gotten a few questions, a lot of them kind of related to attribution, looking ahead to asking questions about the patient relationship coding, all very good questions. Unfortunately, we've kind of run out of time for today. Just note that you will receive some dialogue from us via email as we kind of answer your questions. And with that, we're going to thank you for your time today. Again, thank you, Beth. That was really a great presentation. I hope all the attendees have gotten some good information and are leaving here with a much better understanding of the cost category. Again, if you're struggling at all, reach out to us. CMS is paying us to be out here helping you. We are eager to help you with this stuff, so you're not alone. Don't struggle alone. Let us help you through this process as well. And with that, thank you all for attending today, and we look forward to seeing you on future broadcasts.